in the audience, if you have questions, please either type or raise your hand and we can, unmute you so you can ask your question yourself. And while people are trying to do that, so Mark, can you give us a sense of the duration of responses with those beautiful water plots? How durable are those?
For the trastuzumab deruxtecan, they're very durable. I mean, just really, really impressive considering how heavily pretreated those patients are. The fact that they have such long median PFSs associated with them as well is really, really important. The other thing I should mention about trastuzumab deruxtecan is that like TDM1, it may well get into the brain. We know that TDM1 has about a 30% or so response rate in patients with HER2-positive brain metastasis. And I expect that this new antibody-drug conjugate may well have similar or even better efficacy in the brain. But with only 24 patients in that registrational trial, it's not as much evidence as we have for tucatinib, where we have randomized data, statistically significant results, et cetera. So I'm more comfortable for my brain metastasis HER2-positive patients treating them with tucatinib-based therapy right now, but there will be studies of trastuzumab deruxtecan in the future in brain mets patients specifically, and we'll have to see that may rival some of the tucatinib data in the future. We'll have to wait and see.
And are you getting intracranial responses in untreated brain metastases that haven't been treated with the radiation yet?
Most certainly with the tucatinib HER2 climb regimen, that was observed in the pivotal trial. I don't know what fraction of the 24 patients in the phase 2 trastuzumab deruxtecan trial had untreated brain mets. If there were any, it must be a very low number, so we just don't have enough information to draw any conclusions there. But for tucatinib use, I mean, you could use tucatinib to delay the need for stereotactic radiation, for example, which could be important.
Mm-hmm.
Since even stereotactic radiation, especially if it's to multiple lesions or done multiple times over time to different lesions, that can lead to cognitive impairment at some level over time. So the longer we can stall that, if successful with a systemic agent, then we should probably take advantage of that. So that's another opportunity for consideration of tucatinib in patients with HER2-positive brain mets that are untreated. If they're small and asymptomatic, I think you could use systemic therapy first before local therapy.
Great. And are you getting a sense of if people, when they progress, are they progressing in the brain sooner than extracranially, or is it just concordant with the rest of the body?
No, I don't think that there's any increase in brain metastatic relapse following the use of any of these newer agents like tucatinib or trastuzumab deruxtecan. Overall, about half of all HER2-positive metastatic breast cancers will eventually get brain metastasis, so it's extremely common. But there's no more increased incidence of brain mets following progression on any of these newer agents, to my knowledge.
Great, thank you. Let's see. So we have a question from Dr. Nabeen Karki. What are your preferred chemo agents for metastatic TNBC in first or second line for regular use? And preferred chemo agents for metastatic HER2? Any important differences to note?
So for the triple negatives, if they're platinum naive, I like to use platinum-based combinations in the first line. Paclitaxel, carboplatin, for example, is well tolerated. It's used in many different malignancies. We have tons of safety data and efficacy data, not just in breast cancer, but in other tumor types as well. So it's tried and true. Gemcitabine carboplatin is another very well tolerated regimen that's easy to take and can be very useful, especially if patients are ill or have comorbidities or have trouble tolerating other cytotoxic regimens. Beyond platinums, weekly taxanes, weekly paclitaxel, I should say, is certainly very active in triple negative breast cancer. For low volume, relatively asymptomatic disease in patients with high performance status or elderly patients even, you could consider capecitabine as a single agent. It's not particularly active in triple negative breast cancer, but every once in a while it'll buy you some time with relative lack of toxicity compared to some of the parenteral chemo drugs. Eribulin is probably my next choice after that because it did have a survival signal in the registrational trial. And so it is certainly an active agent in metastatic breast cancer, including the triple negative space. Could you repeat the HER2 question? Because I'm not sure I understood the premise of the HER2 question.
So it says, and preferred chemo agents for metastatic HER2.
Okay, so in the first line, I like to use weekly paclitaxel plus pertuzumab and trastuzumab instead of docetaxel plus pertuzumab and trastuzumab. So it's a Cleopatra-like regimen with substitution of weekly paclitaxel for every 3-week docetaxel. And I like that simply because it's less toxic. And in the study published by Dang and colleagues from Memorial, they did a phase 2 study of that weekly paclitaxel plus the dual antibody therapy. And their PFS point estimate in their phase 2 data was spot on with the Cleopatra docetaxel-based regimen as well. So it's likely that it's equally effective as the FDA-labeled docetaxel-based regimen, but it's far less toxic. Docetaxel is a tough drug for some patients, especially elderly patients, patients with comorbidities, et cetera. Weekly paclitaxel is a lot easier for them to tolerate, and so I generally prefer that for the dual antibody. In the second line, I'm still usually using TDM1. Unless they have brain metastasis, then I'll use tucatinib. And then third line, I do a balanced discussion after TDM1 between tucatinib versus trastuzumab deruxtecan in patients without brain mets. I'll still present both as options, but if my preference, if I'm asked, I will tell them that trastuzumab deruxtecan appears to be more active just in terms of response rate and clinical benefit rate.
Great, thank you. So let's see if anybody else has other questions. Wike, I have a more general question for you in the adjuvant setting. What would you classify? What would you consider as a threshold for absolute risk reduction that you consider as significant for defining success in the adjuvant setting? And similarly, a question related to duration of treatment. Like, when do you actually tell your patients that, oh, maybe you're close to cure? Like, how long do you follow them for? Because breast cancer can be notorious for relapsing, several years, even decades after initial presentation. So how do you counsel your patients on that?
Yeah, great question, and multiple questions actually. And so I'll tackle the first one. I think we all have value and benefit and toxicity that we have to juggle in our brains to say when is something acceptable. Certainly, when the ratio is flipped for number needed to treat and number needed to harm, or number needed to harm is actually substantially more than number needed to treat, we have to be very thoughtful about making the recommendations, or at least counseling our patients about the converse harms associated with the benefit. Having said that, you look at most of these trials in the adjuvant setting, and there are many of them are in breast cancer, are kind of huge, 6,000, 8,000 patients. And so many of them are powered for 1 in 30 type benefits, 3%, 4%. And what's interesting is that as we just become better doctors and providing our care and checking off all the boxes, crossing all the T's and dotting all the I's, in every study we take, you'll see this phenomena where, let's say we assume the placebo rate of some event is 90% in our calculations, and we power the study for 93%, that 3% benefit. What's consistently happening is that 90% is 92%. And I don't think it's because the drugs are better. That's not what's going on. I think we are just becoming better at delivering the care we intend to deliver. It's almost like we need a fudge factor of a couple points to design our studies. But that's, again, happening in the adjuvant setting. You look at that trial with the Palace trial, 90% is what you saw in kind of the endocrine therapy alone rate. That probably needed to be at 82%, to be safely clear that you would have enough benefit to demonstrate. We look at the trial of pertuzumab in the adjuvant setting, which is unimpeachably a very strong, potent, active molecule. And there you have a 1-point-something% benefit that, over subsets, you've eventually found a group that benefited from it. Fortunately, a lot of these molecules are well tolerated. They're being given for a short period of time, 1 or 2 years, and it's, it's feasible to do. But I think as clinical trialists, we need to take a deep, hard look at how we design these trials. We have a huge advantage going into the future, which is that we have biomarkers that help us select truly the patients that are at highest risk, and then enriching the studies for those. So for example, you've heard of the Oncotype DX, we have MammaPrint and others that are emerging. As we stratify patients based on those biomarkers, maybe we'll see better signals. It's interesting, the third of the CDK4/6 inhibitors, which is ribociclib, if you look at their study, one of the biomarkers that they incorporated was Oncotype and MammaPrint. So these gene expression tests, which I think will be helpful in distinguishing the patients that are most likely to benefit from these therapies. So that's the first part of it. Like what's the benefit? It's, eye of the beholder. But in general, if you look at the large adjuvant trials, we're trying to get 1 in 3, 1 in 4 sort of, 1 in 30, 1 in 25 type benefit, which for expensive molecules, raises some eyebrows, but that's kind of where we are as a society in the United States. And then in terms of counseling patients, it's interesting. I do believe that we are doing better than what we have. It's like a stock market portfolio prospectus. It says past returns are not guaranteeing of future returns, right? I have to sort of say, hey, this is where we were and this is where we are, and have to be optimistic. In general, for most of my patients, we're looking at survivals between 92 to 98, 99%. Of course, if you have large volumes of disease and other things, the numbers look a little less good. But the goal is to bring those numbers up to that. So that's how I counsel people. And then now again, with this extended decision-making therapy tool that we have, maybe we have a little bit more help to say, hey, you are a patient that's at risk. And then guess what? This drug actually works and helps reduce that risk. So sort of reassuring patients in that manner. It's a complicated question. It's a complicated answer, I realize.
But great to see all the progress. So one last question from Dr. Carolyn Wild. For which patients do you use MammaPrint versus Oncotype DX?
Oh my gosh. Mark, close your ears, buddy. I really don't enjoy the Oncotype DX. I don't, over years, I have to be honest, our pathologists are so good that we could predict what the Oncotype DX score was going to be. And I realize it's made all the indications and labels and NCCN guidelines, this, that, and the other, but I actually prefer the MammaPrint. I think it helps me be a better doctor for my patients. But I know that the guidelines are very skewed towards the Oncotype DX. So in truth, I use both. I see patients having had both, but I find personally the MammaPrint helps me make decision-making better with my patients.
Can I do a follow-up?
Yeah, please.
Please do, Mark.
So I'm not going to champion either one of those. I'm going to champion something else. Let me tell you about the Optima trial done in the UK on 313 patients getting standard adjuvant chemo and endocrine therapy. All 313 had PAM50, MammaPrint, MammaTyper, IHC4, Oncotype DX, and IHC4 Aqua. So all those assays were run on all 313 patients. Oncotype DX predicted a higher fraction as low risk than any of the other assays. So if you really don't want to give chemo to your ER-positive patients in the adjuvant setting, do an Oncotype instead of a MammaPrint. You'll treat less people with chemo. 82.1% versus 61 to 72% with the other assays. So I find that disturbing because it tells you right away that all these assays are not culling out the same low-risk group. They're culling out a low-risk group, but not the low-risk group, perhaps. 60.6% were assigned to different risk categories by different tests. Only 31% agreement between 4 of the 5 tests. Discordant subtyping, luminal A, luminal B, et cetera. Discordant subtyping was observed in 40.7% of the tumors with these various assays. So what that means is that none of these are probably right. MammaPrint was based on a very small number of genes on the original gene chip array that they used, and the number of samples they used to identify that gene chip signature was only 44 patients without relapse at 8 years and 34 with the relapse within 5 years. So pretty arbitrary cut points. You'd never imagine doing that with such small numbers in 2020. And Oncotype is all supervised, so it's selected genes. It's not unbiased. So the answer to this is the internal cluster classification system published by Christina Curtis here at Stanford and Ali and colleagues in Nature a few years ago. There are 11 different internal cluster subtypes of breast cancer based on copy number considerations, and it's very faithful in large cohorts. There have now been validation over 7,500 samples, and it's crystal clear that this is a better assay. It's prognostic. All 11 subgroups have unique prognosis signatures, and it's predictive for response to chemo. And it's a graduated line. It's much more resolution than PAM50. So the multi-gene assays like Oncotype and MammaPrint were important. They're their first foray into that multi-gene technology, and it saved chemo for tens of thousands, hundreds of thousands of patients, and that's wonderful. But it is not. Neither one is the best assay. So we need to move on and get on to the second generation assays that are using unsupervised data and looking at all of the landscape of the genomic architecture.
And I agree completely with you, Mark. As the assays develop, you're seeing that the dark space in the DNA has a lot of information buried in it, and none of these assays that just focus on gene expression get us there. So it's going to be a much more complicated answer with a lot more research, but totally right. Absolutely.
Right.
Well, that was great. So it was a fantastic session to kick things off this morning. I want to thank both of our outstanding speakers for covering, very complex topics with a lot of exciting developments. So thank you. Sam, Widhi, should we move on to the breakout session for the exhibits?
Yeah,
And then
absolutely.
people can stay in the main chat room as well, I believe, if they want to, right?
Yeah, so people who want to move over, who are already assigned and had been in the main exhibit room from beforehand, can go back down to your breakout session and choose to rejoin that session. For those of you who have not gone to that session yet, I'm about to send your invites over to go over there, and we can listen to the vendor presentations if you wish.
Great.
So when you see an invitation to go join the main exhibit room, go ahead and accept that if you'd like.
And Mark, I think there is one more question for you in the chat.
Sure.
It may probably, I'm just trying to see, Binay, should we address that now, or should we let Mark respond in the chat? I don't want to mess up the breakout plans.
Dr. Kashari, right?
Mark, can you respond that to question in chat?
It looks like a wet regimen.
You can talk to him while everybody else is moving to breakout.
Okay, so I'll respond in the chat. I'll just type my response then.
Okay.
He's
Okay,
also
thank you.
in the session if you'd like to just talk to him too.
Yeah, you can talk to him too if you wish to.
Is he on the line? Can I hear him?
Yes.
Oh, okay, great. So you guys can go to the breakout while I talk to Rajiv. Regimen do you suggest for triple-negative breast cancer patient whose adjuvant therapy, first and second line, has failed, and there is time where you suggest to stop therapy and go for palliative care? Well, certainly if patients have very poor performance status and laboratory parameters that aren't nominal to consider additional systemic therapy, even with the antibody drug conjugate, which that does happen sometimes, where patients are just too sick even to consider sacituzumab govitecan. So in that case, palliative care and or hospice sometimes, sadly, is an important option to consider even after first or second line triple negative disease, because the pace of that disease sometimes can be so devastating, especially if they get central nervous system metastasis or leptomeningeal disease, et cetera. So the answer is yes, there are patients who probably shouldn't consider salvage therapy if the pace of their disease is rapid, if their performance status has declined rapidly, and certainly if they have something like leptomeningeal disease, my enthusiasm for systemic chemo in those patients is diminished. Great question.